also have something that appear on your screen to let you know that this meeting is being recorded. Thank you.
Myers, just for verification, that was fine, right? Since it's just discussion.
I'm looking through my Robert's Rules of Order right as we speak. If I see a problem with a quorum absent, I'll chime in immediately. Okay.
Thanks, Myers.
Sounds good.
I mean, we've never had a problem on investment committee. We just couldn't vote on anything. We could still do the presentation. We just couldn't vote on anything.
Hey, we're lucky when I learned things first time. So let me immediately. Okay, I'll report back shortly. If you don't hear back from me, we're fine. Okay.
Thanks, Myers. Okay, so it's Wednesday, April 14th, 1:06 p.m. Linda, would you go ahead and call roll call?
Okay. Okay.
Please.
Amanda Cox. Absent. Barry Vest. Absent. Caroline Sudlow. Absent. Dwight Vandevoot. Absent. And sitting in for Michael, it is Peggy Kane.
Present.
Okay. Casey Stone. Absent. Lisa Gerald.
Present.
Okay. Linda McGinnis is present. Carter Pack. Okay. Courtney Durrett will probably be late. Nikki Davis. Absent. Randall Kinner.
Here.
Samantha Chittum.
Here, sorry.
And Buddy Burkhart.
Here.
2, 3, 4, 5, 6. Okay, we don't have a quorum yet. So no quorum right now.
Okay, so with that said, for now, everybody, we're going to skip item number 2. That's the approval of the 2021 February minutes. We're going to go to item number 3. It's the Blue Cross network change. Stephanie's going to talk to us about that. I know I had quite a few questions from team members, so I'm sure you all have as well. So I'm sure Stephanie's so excited to let us know about all that fun information.
Yeah, thank you guys. I actually put this on the agenda knowing this was gonna hopefully come out before this meeting and then that we could discuss it at this point. We basically found out around February through kind of rumor mill. It was being talked about, you know, that Tenova was in contract negotiations with Blue Cross and that there was a likelihood, it still was not decided upon at that point. They were still negotiating with each other the terms of that contract. Basically, high level contract, hospitals contract with the insurance providers to be in network. They contract basically their own terms separate from ours. So even though we're self-funded and we do our own contracting with Blue Cross, this is outside of that. And so those were happening. We heard about it. I obviously was not happy to hear that they were proposing this change as of 6/1/2021. We typically get changes like this to start at the plan year. It gives us time for any strategic planning, communications, infrastructure changes, just the whole, I mean, as Samantha really probably understands as well, having worked in this department, just everything that goes with that kind of a change. So Drew and I, and actually our sales team at Blue Cross was great about trying to give me as much information as they could. This was even above their heads. This was really the powers that be at Blue Cross, the powers that be at Tenova, going head to head with their own negotiations. So we decided to try to get in on this. And we wanted to go ahead and appeal to Blue Cross for an exception to the 6-1 change. We were hopeful that we would be able to basically be a group that would be excluded from that change, at the decision of Blue Cross. And, I'm not sure where Tenova kind of fell in those negotiations. I don't think they were, able to negotiate on our behalf either. Our sales team at Blue Cross was even lobbying for us in the higher level as we kind of explained all of the challenges that this would bring us if it were a 6-1 change, being that it was already February and we were talking about this and we were running out of time, as they hadn't come out with any announcement, they hadn't made a firm decision yet, and we hadn't notified our members yet. And if we were going to have to react to this change, we needed it to happen sooner than later. We involved the mayor's office at that point, feeling that maybe he would have more appeal to them than I do, and saying, please don't do this to our group. We are coming out of a pandemic. We're trying to recuperate from all of the things that has caused, and we really love an exception. Finally, they denied it. It was not long before the communications actually went out to team members. And that was actually the same day that I sent the notification to the insurance committee. I'd already put it on this agenda item because I knew it was coming. They still had not, they finally landed on negotiations and still had not notified anybody. So I actually made the request to Blue Cross that they do that. I didn't feel like that should come from my office, being that it was completely out of our hands. It was their decision. It was their lack of negotiations with Tenova to keep us in that exception. And so they did send out notifications within a week of my request. And so that was when the public notice was made. And I mean, that was somewhere around, maybe a month ago. I'm losing track of time here now. But so at that point, we basically knew, okay, they've denied our request. What do we do from here? And so once we knew, we were going to be denied and that this change was going to happen regardless, that's when we sent out the information from the mayor's office, hopefully getting some input from members, trying to find out how much this affected our group. We had already done some data work where we pulled the numbers to see what kind of impact we were talking about. It was enough, it's enough people that it made me concerned to, that the change was happening, but it was also a small enough number. And we're talking, less than 10% of our population overall that used that facility, those two facilities. So it was a big enough number. I cared about those people that were going there, but it was small enough that we were also very concerned about just knee-jerk reaction, opening up a network P for everybody, which would mean losing discounts that we currently have in Network S, and the potential impact of that. So ever since then, we've basically been very strategic about how we move forward. And so that's kind of the place that we're at right now. I'll kind of pause there and see what I wanted from the committee and what I wanted to discuss with you all is, one, addressing your concerns. And then I do have some proposals for changes for 2022. And then also maybe explaining why we can't make any of those changes happen before the 6/1 date at this point. We expressed our disdain for this. I had very stern conversations with both Tenova and Blue Cross about the fact that their lack of negotiations basically put plan sponsors and members in the middle of this, and was really going to just result, no matter which way the decision fell, in us having to bear the cost of the fact that Blue Cross would not keep Tenova in Network S, and how ridiculous it was to be occurring during a pandemic. One thing I will preface before we have questions is that I did a lot of research to also find out if this is just a Blue Cross thing or if this is just a Tenova thing. Why is this happening? And what I found was this has actually happened with Cigna, it's happened with United Healthcare, and it's happened more than once, and it is always Tenova that is out of network. And so a lot of that is based around utilization, cost of care, those kinds of things. And so we've just kind of been a little bit spoiled to the fact that we've had all three in network for about 5 years now. And it's been really nice because we could still have those discounts and use those facilities, but we're kind of back to the place where Blue Cross has reevaluated the idea of a narrow network. And because we have two other major hospital systems that are in network, the one that we had the least amount of utilization, the least amount of disruption with, is the one that is now out of network S. And so that just means that, you know, we have to adjust the way that we do things. And so I'll kind of stop there and open it up for questions and see where I can fill in the gaps beyond what we've already communicated and where you guys still lie with this.
Do most of the doctors that work out there at Chernobyl, do they have privileges at other hospitals?
They do.
So it's not gonna, they can go someplace else if they had to.
Yeah. Yeah. And I was told by several people also that there may be a few specialists who don't yet, but that they were well aware of this change, and providers don't want to lose their patients. They don't want to lose the business. And so it behooves them to contract with these other hospitals to gain privileges to be able, because ideally if I go to a Covenant or a UT and I have a doctor out at Tenova and say I'm in that hospital, then my doctor would want to have privileges at that hospital anyway to be able to see me there. So I did find out that the majority already have dual privileges at our other area hospitals, and the ones that don't, we're working on contracting that because of this change.
May Myers interject something? Will the chairman keep track of the quorum, please? And keep track of how many people are present. And as soon as we have a quorum, put that in the record, mention that.
We have one now.
Yeah, Myers, I wrote down Casey Stone joined at 107. So that gave us 7 people. And then Caroline Sedlow joined at 114. So that gave us 8 people. So I guess we officially had a quorum at 1:07 p.m.
In that case, never mind.
Randy, that was a good point. I was going to say the same thing to Stephanie, because I know my ENT, his group actually is at Tenova, UT, and gosh, what's the one out west by Calhoun's on paper? There we go. I can see him all 3. I typically go to Tenova. It's closest to work, and I don't have to pay to park. Because that was what I was going to ask Stephanie too, if she knew of all the members that were actually affected, how many were in that scenario that you had asked about? Like, is there a provider? Can they just go to a different location? Might not be most convenient, might not be their preferred choice, but they can still see that provider. They're just going to have to go to a different place. But do you even have the numbers on that, Stephanie? Or you just said, there was a good number that could do that? Yeah,
I mean, we know how many people went to those facilities, but as far as narrowing down who has, doctors that would be a much deeper dive into the data that I don't even know would be possible at this point. The survey though, that we put out, we wanted to ask in that notification we sent out from the mayor, we did the survey. It was very telling. And I've done a lot of kind of one-on-one with people, just asking, and I support Tenova as a community partner, as a taxpayer. I hate that this has happened. I've told Blue Cross, this is really not an ideal situation. No matter what we do, it's going to cost us more money. And my main responsibility as this plan fiduciary is to make sure that we aren't making decisions based off of, just random things pulled out of the air. So we're looking at the data, we're looking at how much we're saving, we're looking at the possibility that even if we open up a network P option, if we don't clearly communicate to people who don't even go to Tenova and they just think that, well, P's a better network and I can afford it, I'll go ahead and opt into there. What they're doing at that point is taking away all of the discounts that they're getting for services that they're already getting that are no different. And so basically costing themselves and the county more money, because down the line, that's all going to come back in premiums. So if our costs go up, then our premiums go up. And that's what I don't want to happen. And so it's one of the reasons we've tried to be really strategic about how we're approaching this going forward. And I do think we need a Plan P option, but I think it just needs to truly be for the people that have to use those facilities and are willing to pay that extra. And I'll tell you, in our survey, 64% of people that responded said this didn't even matter to them, that those hospitals didn't matter to them. 22% said yes, but then only 2% said they would be willing to pay more to go to those hospitals. So that really tells me, and we had a lot less negative feedback and disruption than I even expected when this first came out. I was thinking it was going to be massive, but it's like, as people realized and as we kind of did our homework and said, okay, this isn't as bad as it seems. Historically, there have always been 2 hospitals in Network S and 1 out, and we've always dealt with it. And there was a time when, North Knoxville didn't even have that hospital there, and we always managed as well, because geographically you can get to one of the others. We're very fortunate to not be like some of the rural areas that really truly are without a hospital system when they shut them down. So, that made me feel a little bit better. I would like to offer a P network option. So I am going to put that on the agenda in a couple meetings from now, maybe, where we can outline a strategic plan going forward. But it's going to cost more, obviously, because those claims that run through Network P are just going to be much higher, because you're losing those Network S discounts that you get. The very first question that was proposed to me was, well, can't we just go out to bid and rebid on this insurance and get rid of Blue Cross? And I mean, if that were an easy fix, then yes, but it seems like United Healthcare and Cigna and other carriers have done this too. So we would still possibly be in the same boat if we only ever just carry a Network S. But we just don't want to slap Network P on the options that we already have, because there's well over 2,000 people that this is not affecting, and in our plan. And so those 2,000 people that this does not affect, they're perfectly fine with what we have. Why would we spend more money on their care? Why would they want their premiums to go up because of this? And when I just weighed the pros and cons, it just wasn't worth it. And if it were a detrimental change and we needed to spend the money because it was worth it and it was going to be a huge impact to our group, it would be a no-brainer. And that was partially why I think we struggled so much with this decision, because it felt like it was enough of an impact, and we care in general anyway, but it was really enough of an impact to pay attention to it, to do our homework, to be very strategic in going forward, what we're going to plan on offering to, hopefully give people access who truly need it, but then preserve those discounts for the rest of those who don't need this, who wouldn't be affected by this, and hopefully enrich the plans that we've currently got. So I'm hoping to have that on the agenda by June or so, but I would like to answer any other questions people might have about this change. I think it's important to also note that you can still use the emergency room at Tenova facilities. If you're close and you have a true emergency, please do not go to a hospital further away because it's out of network. They will still pay in-network rates for that emergency room visit. And they basically will stabilize you and then transport you to an in-network hospital. And so do use the emergency room if it's a true emergency room. And so that was also helpful in deciding, because we didn't want to limit access to care for those emergencies.
Stephanie, I have a question.
Yes.
Say we have somebody who thinks they're having a heart attack and they are living close to Tenova. They go there because it's the closest, and it turns out not to be a heart attack. It's, say they have an esophagus spasm or something. Would that claim be processed as if it were in network as a true emergency? Or since it wasn't actually a heart attack, would it be at the out of network rates?
They would at that point, if they identified that you weren't indeed having a heart attack, would then transport you for care to an in-network facility as well, I believe. And that should still...
Yeah, Stephanie, let me jump on. This is Drew. Can you guys hear me okay?
Yes.
Okay, so that's a good question. So regardless of the diagnosis, Lisa,
Yeah.
that's an emergent situation. So just because you didn't end up having a heart attack doesn't mean that wasn't an emergency. So let's be real clear with everybody on the call. That would be treated as an in-network claim.
Right.
If at that point they send you home because you just had acid reflux or whatever, then that claim would be paid as in-network. Where Stephanie is, where we run into a little issue, 5 years ago, we used to run into this. Let's say that this individual did have a heart attack and, they can't just put them in an ambulance that night and move them to another facility. So only these claims are all paid in network, and the patient is only moved when it's in the best interest of the patients from a stability of care standpoint. So I want everybody on the call to understand these things are going to come up, and this is not going to negatively financially impact your employees. If we're under an emergent situation, all claims are treated as in network.
Thank you, Drew. Yes, for clarifying. Yeah, they're gonna, if they're sending you home, but you came in for an emergency like a heart attack, it's a good thing that it wasn't a heart attack. So, but it would have still been cause enough for somebody to go to the emergency room. We don't want people questioning, should I go? Is this enough of an emergency? We'll iron out those things later.
I have a question. Will Blue Cross Blue Shield be sending out letters when this becomes effective? Like if they're going to a Tenova doctor and he does go to Tenova North, I mean, that's where he normally goes to. Are they going to receive a letter from their doctor or from Blue Cross Blue Shield telling them, at a certain point, they're going to end up being out of network?
I believe the communications have already gone out from Blue Cross, so there may not be more from them. As far as providers' offices, that's up to them. I know Tenova has sent some stuff out from them to their employees. I am aware of some communications that went out from them. But as far as Blue Cross, I think that their notification that this change is happening effective 6/1 has already been sent out. That's what we got just shortly, but around the same time I reached out to the committee to let you all know that it was coming out.
Let me address part of that too, Stephanie. So if you're a physician's office at Tenova and all of a sudden you realize that Blue Cross patients, your Blue Cross patient population can no longer have inpatient or outpatient services at Tenova. So it's changed your process as a physician. They're going to do those MRIs. They're going to do those, the upper and lower GI. Those are no longer going to be scheduled at Tenova. So the way that works is you go to have a procedure done. The doctor's office calls Blue Cross or whatever insurance company it is to get a prior authorization to do that procedure. If the doctor says we're doing it Tenova, then the doctor's office is going to be notified that that's out of network. So okay. There's a process in place. Could early in this June and July some problems arise? Absolutely, because you have humans involved. So if you have your colleagues that you work with who run into a problem, I just want to encourage you to have them reach out to Stephanie's office and we'll get this stuff fixed. There's going to be some things happen here, but we can fix it on the backside.
Okay.
And actually one of the perks to this has kind of been, something that we've educated people. We don't want you going to the hospital for an MRI or a CT scan if you can help it anyway. It costs you out of pocket a lot more money than if you go to an independent imaging facility that's in network. And so it almost incentivizes people to go to those facilities even more now and avoid that extra, I think it's $125 copay plus cost up to deductible and then 80% coinsurance versus just the $100 copay you get at the independent facility. Because it's just a much cheaper charge. They don't have they have fixed costs at independent imaging facilities. So they're able to do that much lower cost than hospitals are. So we want that anyway. So this is actually going to kind of incentivize people a little bit to go away from the hospital for those imaging services.
Hey, when several years, well, not several years ago, but a few years ago, when we switched from Humana to Blue Cross Blue Shield, it seems like Blue Cross and UT Hospital got into it over something, and they cut some people off one of their plans, but it wasn't very long before they managed to work it out. I don't know, maybe one of them decided they wanted the money, or it was hurting too much not to have the other one. Is there any possibility that will happen here, where in 6 months from now they'll work it out?
It is my understanding that that would be a no. I was hopeful that that would be what happened in this case. I was kind of holding my breath, waiting for somebody to negotiate and figure this out, and then it not to be true. I think Drew can speak to that. I was probably a bit of a pain to them for a little while, saying, why can't you just help us out and agree to this? You know, and I was really, I mean, I drug them, I drug them through the mud a little bit, and they do understand. And sadly, our sales team has been awesome. We've received wonderful customer service from Blue Cross. I'm very happy with their service. I'm very happy with the money that Blue Cross can offer the discounts because they're big enough to do that. And so it's also why they can kind of take a hard stance with these hospital systems on what they expect and what they would like to negotiate. And I kind of stand behind the carriers that way. I do feel like if we cave every single time they have a lack of ability to negotiate, then what we're doing as plan sponsors is really kind of playing into this healthcare system that where costs are going up and we're willing to pay it. And until we're willing to walk away a little bit, I don't think that they have any incentive to negotiate on our behalf. And so, you know, I don't hold Blue Cross completely responsible for this. I think it's a two-way street, and that's why UT and Blue Cross were able to come to terms, and unfortunately, Tennova wasn't. And so, you know, we're still wanting to offer that P network. I think we're just going to be a little more strategic about it on the back end, and then be very smart about how we do that as far as administratively making sure it's right and making sure that it's not going to impact us greatly.
Okay.
Yeah,
Thanks.
Stephanie, let me throw a little more color on that for the group, because I think if people don't understand why it really matters. So if you have all three hospitals in your network, the hospitals don't give you quite as deep a discount. So unfortunately, why I think this instance is very different than UT is for two reasons. Number one, UT just has a greater market share than Tennova. And so UT is just more important from a customer standpoint, a customer experience standpoint. So the loss of UT was really negative for Blue Cross from a perception standpoint. Tennova, unfortunately for our community, not so much anymore. It's sort of kind of the not thought as readily as Covenant and UT. Secondly, financially, this would really negatively impact the discounts we're getting, because UT and Covenant will say to Blue Cross, which means to Knox County, hey, if you only have two hospitals in the network, we can get a better deal. And so there's a lot of negotiation that's bigger than Knox County on this. What Stephanie and I were really frustrated about, it was really the timing of this. We understand that insurance companies have to negotiate contracts. Our point that we were kind of willing to die on the hill for was, that's fine, but you should have told us in October, because I still believe they knew this was going to happen. And so to defend Stephanie a little bit, this caught us all off guard. We have 400 clients in East Tennessee that have all had to deal with this. And it's been hard because most of them renewed January 1. And here we are mid-year dealing with this nonsense. So Stephanie's really stepped up, but we ran into a wall. So the short answer, which is way too long, which is I do not think this thing's getting turned around in the near future.
I was hopeful it would. I mean, I am happy to say we did also talk to our business group partners. We conferred with all. I mean, I must have been on the phone, and even with our members, every time I talked to somebody, I would interject and say, hey, by the way, do you use Tennova, and how do you feel about it? Because I really wanted to know how much this mattered to everybody, and it's part of why we surveyed the population, and it's part of why we talked to all of our partners and seeing what they were doing. And everybody was just kind of at a loss. Like, I don't really know. And we have groups that are starting, they're playing year 7-1. So now they have this situation where they have a month And, luckily we have a little bit more time to plan, but if it were UT, it would be a no-brainer. We would have already made some adjustments and some changes, and I would have been willing to take on the administrative cost of making that happen. But it like Drew said, it was a smaller impact. It was small enough for us to feel like it would be more detrimental to knee-jerk reaction and jump into Network P just to save Tenova, when I didn't really have any strong background to say that was even necessary. And the more people I talked to and the more people that I got feedback from on even those that use Tenova and their feelings about Tenova in general, it was it was a lot harder to make that decision. And so we've kind of pumped the brakes a little bit and want to involve the committee in being very strategic going forward and how we do this so that it's not going to impact us. And like I said, what I don't want is for people who wouldn't be impacted by this change at all anyway. I don't want them to jump into Network P just thinking that it's a better network and just thinking that it's going to get them anything more than what they've got, because it's really not. Network S is very wide in this area for it to be considered the narrow network. It's East Tennessee's actually got a lot of coverage, and so it's why we've been able to save money through those discounts. And so I just didn't want those people that this didn't impact to think that that was just automatically a better offering. And I really wanted people to understand what this meant and preserve kind of where we've tried to keep our premium raises minimal and, keep our impact minimal. And we're also still watching our costs from COVID and things like that. We're trying to be very smart about how we handled this issue. And I would have loved for them to have worked it out and it not to have happened at all. I had other things I would have liked to have been focusing on this last couple months. And this definitely became a priority. And Drew knows I was emailing them and messaging them at 5 a.m. and they think I'm crazy for that. But it really, when you're dreaming about network changes at night, it was almost comforting to hear back from people and say, okay, we can handle this. We'll be okay for the rest of this year. And then some even say, I'm still not willing to pay more, so I may find another provider. I mean, we even had people tell us that. And so it was like, we're gonna let this thing play out and then go forward. But yes, the timing was horrible. That was the worst part about it for us. We would have obviously liked to have communicated this back in the fall when we were doing open enrollment, and having 2 open enrollments a year is almost, ridiculous to think about for something like this that's got such a small impact to our group of 2,700, or 2,300 on the plan. Does anybody else have any other questions? I hope I covered everything.
Thank you all for everything, your department. And I know it's a lot of work. I remember when we were switching from Humana to Blue Cross, the contract with UT wasn't signed yet, I don't think, when we were in the early stages, and then it happened. But that is a big thing. Like you said, just educating the people not to pay more for the P just because they're scared. Do it only if you need to, because of that. That's just going to be I know that's going to be a lot for you all this fall if that's what we end up doing. So it's
yeah.
great to know you care.
And we're planning. Yeah. And we're planning on that. We're really planning our entire open enrollment around this change. We still have pharmacy, guys. That is still a major priority for us too. And so we're really trying to balance how much of this we need to handle right now versus the challenges as well of communicating. You all know of communicating with our groups and getting the message across. It takes much longer than, what is this, April? I mean, I would have to have all of this. By the time they made a decision, I had about a month and a half to make anything happen. And it takes longer than that to communicate something like this to people and really have them pay attention. And then sadly, what I was afraid of as well were the people that were going to fall through the cracks who it did matter to. And then, we wouldn't have been able to do anything, and maybe they didn't get the message. And you just really want, and Blue Cross knows this. And, our sales team felt horrible about this. They were obviously at our beck and call they were giving me all of the information I asked for. They were really bending over backwards for us. I truly cannot speak highly enough about them. This is not on them. This is way above their heads. And we did appeal. They lobbied on our behalf. And I really felt like that, they were calling me and reaching out and going above and beyond what I think was even expected of them. So I think it'll be okay, though. I'm happy to say we've had very little since the information came out. The only people that I talked to were the committee members. I have heard zero from any other members as to, we heard a little bit before the announcement came out because other people, were hearing the rumors as well. And once we explained it away that, oh, you can still see your doctors, oh, you can, because providers are paid the same no matter what, it's just the facility. So you could still see your doctor, you could still go to the emergency room, you can get your imaging somewhere else. They were like, oh, okay, good, and it wasn't the 9 alarm fire that I felt like it was. And so that was very comforting. So it made us feel even better about the decision to be a little bit more strategic in how we open up P. And we do still want to offer that. I do think it's important because even if we leave Blue Cross at some point, there may always be one hospital network or somebody that's out of network, and we want to be able to have that P option for those people that need it. But we're definitely going to communicate that away and spend the majority of this year focusing on that, and focusing on our pharmacy, and then focusing also on our wellness initiatives and the things that we're trying to do to recover from this pandemic and enrich our benefits package and enrich our communication streams. So that's our priority. I greatly appreciate you guys for listening to us ramble about all of this, but I truly want to answer any more questions if anybody has any concerns, anything that we may have missed. I feel like I probably beat this horse till it died a long time ago, but it was important for us to really tackle this from every angle. And we have come up, I've played devil's advocate with myself on this for quite a while now, and I feel very, very comfortable. The mayor's well aware as well, and I think supports us in moving forward and understands that we've done our homework, and now we just need to move forward from it. And then we'll take care of our members, and we're always here to hear anybody's feedback or questions later, obviously, if anything comes up beyond this meeting. But I just appreciate everybody's support and the fact that you all have put so much effort into also asking the hard questions and letting us help communicate that through you, because I think it does make a difference for you guys to be the voice for our office and kind of play that intermediary. Does anybody else have anything else? I'll quit talking. I'm sure y'all are sick of hearing from me.
I do want to say one thing.
Oh no, you muted.
Okay. Am I good now?
Yeah.
No matter who we're with, whether it's Blue Cross or Humana or anybody, they are always going to have contract negotiations with different hospitals. So, I've had a couple of people say, well, why don't we just go with another carrier? But the thing is, you're not guaranteed that that other carrier is going to have those same hospitals in network the whole time you're with them either. And for me, so far, Blue Cross has been well worth it from customer service standpoint and the claims being actually processed correctly. So I'm upset that they've done this and upset about the timing of it, but I understand that contract negotiations happen, and if they couldn't come to an agreement, there's not really a lot that we can do on our end to make that different.
Yeah, I agree. Blue Cross and Blue Shield, they've been really good. We've had a lot fewer problems with our people on claims since they came in. So even if there's an issue with Tenova, I still like Blue Cross Blue Shield.
I appreciate that feedback, guys. I echo that. We've had 0 appeals this year, and we had multiple with Humana, and I just think that also speaks volumes. We've also audited them twice, and very, very, very little, actually just things to be expected, but very favorable audits for all of their claims for 2019. So I'm happy to say they are providing excellent service. They do give us the best discounts. And this is unfortunately the healthcare system we live in, where hospitals and doctors do their own contracting, and it's outside of ours, and it ties our hands and it puts us in the middle It's unfortunate, but it is something that we are well aware of, and I think we're willing to work around and basically just be, my goal is to continue to be strategic in everything that we do. I'm never going to make a decision that just jumps us from one thing to the next without, it probably drives Drew a little bit crazy, but I actually overanalyze things before I make decisions. And so I just hope that you guys understand that I'm always open to feedback, and I like to explain the why behind things. And so I love that you guys have also experienced good service with Blue Cross, because that was the hardest part for me. Was I told them, this is a terrible look for you all, and it is very unfair that you're getting that, because I think it takes away from all of the great things that you have to offer as a carrier. And I hope that it doesn't leave a bad taste in everybody's mouth, you know. But I'll quit talking. Sorry. Samantha, you're muted.
Oh my gosh, sorry. Does anyone else have any questions for Stephanie on this? Or if not, so I saw Courtney Durrett joined at 1:20, and then Matt Myers joined at 1:30. So if you guys are ready, let's move back to agenda item number 2, the approval of the February 2021 minutes. Does anybody have any questions, changes, concerns on those before we vote? I'll take silence as a no. Linda, would you do a roll call vote, please? You're muted, Linda.
We need to make a
Try this again.
motion.
Okay, Amanda Cox.
Wait,
yeah,
motion.
Wait. Yes, I'm so sorry. Lisa, thank you so very much. Does somebody want to make a motion?
I'll make that motion that we go ahead and vote on the minutes from February 2021.
I'll second.
Second. Okay.
Thank you, guys.
Okay, Amanda Cox. Minutes. Barry Vest. Caroline Sudlow.
Yes.
Okay, Dwight Vanderbilt. Casey Stone.
Yes.
Okay. Lisa Gerald.
Yes.
Linda McGinnis, yes. Carter Pack. Courtney Durrett.
Yes.
Okay. Nikki Davis. Randall Kenner.
Yes.
Samantha Chittum.
Yes.
Okay. Buddy Burkhart. Buddy.
Yes.
Peggy Kane.
Yes.
Okay. Okay, that's 9 approving the minutes. So, and that is a quorum. So the motion's approved.
Thank you, Linda.
Mhm.
Number 4 on the agenda, discuss items for next agenda. Does anyone have anything now they would like to discuss, or any information from Stephanie? Or if Drew and Stephanie, do you all know of anything we need to look at for the next meeting that will be coming up, or?
I'm gonna pitch this to Drew because I'm not sure if we need the PBM next month or June. I think what I would like to do, and what I plan on doing for June, at least I know, is pitching the changes that we would like to make for 2022 that accommodate this network P. option, and then having you guys vote on premiums at that time too. So I'll probably make 2 agenda items for June. I don't think it necessarily needs to happen in May because we still have some time to get some things ready for that. But if he's ready for the PBM discussion in May, I'll leave that to him. I'm not sure if we're May or June for that one.
Yeah, so thank you. I think I would really think that June would be the right time to actually vote on it. So this is such a big decision for the committee. We want to get it right. Our costs have skyrocketed in pharmacy. And while they may not look as bad on paper, our 2 largest claimants that were spending about $1.4 million are not on the plan anymore. So if you look at it, you go, oh, well, we're not running too bad. Well, yeah, we are, because we're still up, but $1.4 million we had 2 people, one on a drug called Humate P and one on a drug called Cinrise. Those 2 drugs combined, just 2 people spent $1.4 million. And we're going to want to do face-to-face interviews, ideally. I know with the pandemic and things, but if we can pull these off, it's such a big decision. And to be able to hear people's story, buying pharmacy is not just who gets the best discount and who gets the best rebate. That's sort of what's led us in this, the world that we're in today. It's really who's going to help clinically manage the health of our colleagues and who gets them on the right drug at the right price, not just who gets the best deal on the price. I think Stephanie's probably texting me right now. I have no idea what I said stupid. So I'll find out here in a moment. So everybody just smile and realize I hate this crap as much as y'all do, Zoom. Probably June would be my, we just got the responses in on Friday. So.
Is there a way on those that you can kind of give us an idea of how involved they are, on how many drugs, as far as when you're trying to compare those different RFPs? Yeah,
and I'll detail that. So part of what y'all hire us to do is to manage this RFP. Lisa, some of my clients, we use this phrase here, it's not the greatest, but we say some of my clients don't want to see the sausage being made. They just want the end result. And so we do all this work behind the scenes, and sometimes we forget to kind of show you guys all the gross details. But there's really 2 main functions that we do, Lisa. We evaluate if you had the same exact drug mix next year as you did this year, what would our cost be? So we assume no changes in drug spend. Everybody's on the same drugs. We're just buying it from a different PBM, same pharmacies, all that. The second thing we look at is where are the opportunities for us to move members from high cost drug A to low cost drug B? And then what's our opportunity there? And who can partner with us best to do that without employee noise? And so, Lisa, I will absolutely share those details. And I know, because you and I, our relationship, I've known you for probably 6 or 8 years. You like to see that stuff. And we'll be happy to share that. However, Stephanie wants to get those details to the committee.
Yeah, I may have an item after today based off of this. I haven't even looked at this yet, so I would hold off right now from me adding anything, and I'll send it to Lisa obviously before the next committee. But the only thing I know of, I don't have until June, so I don't have anything right now unless anybody else does.
A question on that PBM thing, kind of to piggyback off what Lisa was saying. What about people? I know, like when we switched to Optum from CVS, we had like the grandfathering of people in that were on certain medications, and you want to do that for, I mean, there's various reasons to do it, but if a new PBM came on, or if you're talking to these new PBMs, interviewing them, whatever you're doing, how does that work? Like if you know that somebody's on, or people are on expensive meds and they're grandfathered, is there a way, obviously not for you, but for them to be able to look at things like they're a pharmacist, just to make sure that they really needed to be on it and something didn't slip through the cracks, or the doctor didn't know how to write notes to get it covered when they didn't need it to be covered? Does that make sense?
It makes total sense. So I'm going to give you a real quick analogy of why I became so passionate about pharmacy. 7 years ago, I had someone in my family who was on a drug that cost $50 a month. And we were on that drug for 10 years. Doctor gave us 6 months of samples for this new drug. And, you know, I didn't think about it or whatever. And the person in my family said, "Oh, I love my doctor. He's great. He gave me 6 months of samples." Well, the 7th month, we got to fill that drug, and that drug was $6,300 a month. Now, we were fine on the $50 drug. We were doing great. So, Samantha, physicians do not know the cost of medication. According to their own survey, the American Medical Association, 80% of doctors do not want to know the cost of the meds that they write. So part of this is we're fighting big pharma, the best lobby in the country, marketing crazy, and the physicians really don't have time. And in their defense, they can't keep up with how much all this stuff costs. The downside to grandfathering, Samantha, is when we grandfather, what essentially we're saying is we're going to approve Optum's homework, and whatever they approved, we're going to approve it for 3 months or however long we're going to do it. Now, that being said, if there's 3 or 4 really crazy expensive ones, the right pharmacy partner that we choose, we're going to go ahead and have them evaluate that clinically and say, "Hey, I know we grandfathered this, but man, can we reach out to this member that's on Sunrise at $63,000 a year? Can we, or month, excuse me, that's what Sunrise cost. Knox County had a person taking that. Can we look at what else clinically we can do?" So the short answer is yes. The long answer is whatever our grandfather status is, we kind of get married to that. So one of the things that I'm going to really ask the committee to do is consider only a 90-day grandfather. Not that I want to negatively impact your folks, but if I show you all this savings opportunity, but yet we're going to just approve Optum's homework for 6 months, then you guys are not going to save the kind of money that we possibly can. And the pharmacy's strange. I'm talking about probably 50 people out of 4,700 that are impacted by this stuff. It's a really small number of people on these specialty meds. I don't care how much Augmentin costs. That's not where the problem is. The problem is Humira costs $5,000 a month. And how many people do we have on Humira? How many people do we have on, metformin extended release that's overpriced insulin like crazy? Like we have, that's kind of nonsense. So we got to be careful of how long we grandfather. That's one thing the committee is going to have some input with us on. And I'm going to ask for your support on that. I've done it both ways. And if we do it for 6 months, we just lose a lot of the momentum.
I know it's frustrating for people to deal with, but there's so many scenarios that I've heard of people being on medications they shouldn't have really been on. They just thought they should have been. And it's not only just savings, it's just you don't want people on medications they don't really need to be on, or at strengths they don't need to be on, or
these new medications personally, I mean, this is me, conspiracy theorist a little bit. There are so many problems we don't know that arise. I mean, I can tell you this, we found someone that was on an MS drug that did not have MS. And those drugs are incredibly powerful. And they never even had a CT scan with lesions, but one doctor said they thought it was MS. They went to a new doctor. The new doctor said, well, yeah, that other doctor said you have MS. Nobody ever tested for it. And now they're on a drug called Imbruvica, which happened to be $14,000 a month, but they didn't even have MS. So you're exactly right. It's trying to marry being a good financial steward with clinically doing the right thing for the members.
Like I've said before, it's also about saving money so that we can spend them on the drugs that we actually need. We want to be able to preserve those funds and preserve our plan in general to be able to support that and be sustainable in the long term. And when we've got people on drugs that they don't need, and let me remind everybody, this is one of my pain points with pharmacy. I won't get on my soapbox because we don't have all day, but they spend millions of dollars on marketing. It is not our members' fault that they go in and ask for the drugs, and that the doctors also go, yeah, I heard about that one too. Let's try it out because I've got other patients I've got to see today, and they don't want to go back and forth on the best practice is X. They just put them on it and try it out. And we've seen it time and time again. And so the marketing plays a huge part. Lobbying, this is $1 billion industry, and they have a huge hand in Washington. They have a large market share, and every time we get onto their game a little bit, they change the rules. And so just keeping up with that is like a full-time job. But the reason that a lot of people ask for these drugs and don't know about the alternatives is because they spend more money on marketing the most expensive drugs. And that's why the names of all of our top costing pharmaceuticals are well known, because they're on TV, and that should be illegal. Sorry, Lisa.
I just don't want it to get to a point where our insurance company is getting between the doctor and patient care. And I know that y'all are going to be careful about that, but I have talked to my doctor about it some, and she was of the opinion that insurance companies a lot of time have a financial interest. They don't necessarily have a personal interest in the person. And I just want to be cognizant of that as we go through this process.
Yeah, and that's a good point. And that's one of the best parts of being self-funded is we do have a responsibility more than a financial interest. We have a personal interest in our members. We want them to be on the right drugs. And unfortunately, providers have always pointed fingers at insurance companies, and insurance companies are starting to point fingers back at providers. And it's why we spend a lot of time educating our members, because I think the only way that we can truly know is to be empowered for ourselves and to do our homework and to ask the hard questions and to not fully trust everything our providers are saying is as the gospel, because there are alternatives sometimes, and they're just not addressing it because the conversation's either being driven one direction or the other. And so us taking the wheel of that conversation a little bit is really important. And so, it's very easy to blame the insurance companies, but Blue Cross really works for us, and they have, very little financial incentive to make these changes. This is about us preserving healthcare cost in using those funds in the way that's less wasteful and most effective, and that actually has proven patient outcomes. And we're talking about data and value-based care and quality of care being at the forefront of what we're concerned about. And I know providers care about that too, but like we've said, they have how many other patients to see that day? They cannot go through all of these details with you in one visit.
Hey, Lisa, I heard something really good one time that I thought was pretty interesting. So I was calling Blue Cross and I was raising Cain with them about how expensive drugs were. And the CEO of Blue Cross said, "You realize we've never filled a prescription that somebody in a white lab coat didn't write." And I was like, that's kind of a good point. There is so many places to point the blame, why costs have gone up. It really doesn't matter. It's spilled milk at this point. We just have to do what we have to do to control these costs. I will tell you guys anecdotally the story. You guys had a member who was on a drug that was $14,000 a month, and I was frustrated. So I emailed the doctor, said, "Look, I'm not here to tell you how to practice medicine. I just want to educate you that Knox County is paying $14,000 a month for this drug. I don't know if you know that's how expensive it is." And the doctor wrote me this scathing email back. It was awful. First question she asked me was, where did I go to medical school and all that stuff. And I get it. I understand. And she also carbon copied the drug graph and said, "This drug is not $14,000. My patients only pay $5 or $10 for it." Well, they're getting a coupon to cover their portion of it. The doctor didn't even realize that the actual real cost of the drug was $14,000. And so since she emailed or carbon copied the drug graph, I sent a copy of Knox County's invoice. I screenshotted it, just the portion of that drug. Xyrem was the name of the drug, XYREM. And showed them and said, "Here's what we're paying for it. I'd love a response." And I did not get anything back, because I think it was eye-opening to that physician that they had no idea that Knox County's paying $150,000 a year for someone to be on that drug. So I agree with you. We cannot sacrifice care. We just don't want to let the marketing company that is pharmaceutical. Last year, Humira alone spent $360 million in advertising. They don't spend that money because they're nice. They spend it because they know it drives profits. And so if we can help our employees and save money at the same time, fine. But some people are going to have to be on these expensive drugs because they're life-saving. There's new drugs out for cystic fibrosis. They cost $300,000 a year, but it's going to save somebody's life. That's just going to happen, and we're going to be on those drugs. So I hear you loud and clear, Lisa. I'm not going to let this thing get to be a mess, but if we don't continue to change, we're going to have some issues, and then employees are going to have to pay more for insurance down the road.
Thank you.
Does anyone else have anything or? No? If you, oh, sorry.
I'm sorry. I was just laughing at Linda's light. She's been.
I know.
She's on mute.
Yes, I know.
We're all going to get this perfect, and then we're going to be back in person. Fingers crossed.
Well, I do have a question. Are we going to try to meet in person for the June meeting? Hopefully. Or are we still wanting to do this virtually? I wanted to take account this time.
This is Myers, if I could chime in, the governor's executive order 78 that allows us to meet by Zoom currently expires April 28, 2021. Who knows if he's going to renew it or not, but the opportunity to meet by Zoom will expire April 28th unless the governor extends it, which I'll let everybody know if he does. Okay.
Thanks,
Okay.
Myers.
Even if he doesn't, we could still meet by Zoom if we wanted, couldn't we?
No.
Really?
Open meetings.
Yeah.
Awesome.
I think it's because, yeah.
So it's an open meeting because of that order, even though we're opening it up.
No.
And I'd rather meet in person, but I was saying that we should have the option, I thought, but maybe not.
No, open meetings require a quorum and a location, and the location is what's in the public notice. And so the governor, what he's done during this pandemic is suspended the requirement that a quorum be in a specific location.
Okay.
That, like I said, I don't know if he's going to renew it or not. It seems like it's been 14 years we've been doing this, so I don't know. But April 28th is when his current order runs out.
Even if he doesn't renew it, I wouldn't have a problem going back into person meetings again. I mean, we're doing court that way, even though we got everybody as much as possible separated out. I don't mind doing an in-person meeting,
Yeah, we have, I mean, in the small assembly room, there's plenty enough room to space out, and we can space out more if we need be. So I would say after this month, we meet in person unless Governor Lee sends the order, and Myers said he would let us know. So
I'll check on the conference room for next month for the May meeting and the June meeting, just to make sure.
Were those two not available in small assembly, or were those two the conference rooms? I can't remember.
It's been so long since we've been in the assembly room, I can't even remember.
Okay.
I think I had scheduled it for the entire year. I just want to go back and verify.
Okay. Thanks, Linda.
Okay.
If anyone else, if no one else has anything to say, would anyone like to make a motion to adjourn?
I'll make a motion to adjourn.
I'll second it.
So thank you all. It's 2:09. Let Linda know if you have anything for the agenda.